are neurodegenerative diseases. Unfortunately, there's no cure for either of them. They have two separate etiologies, and unfortunately what you'll see is that this one, Parkinson's disease, tends to lessen life expectancy. Multiple sclerosis, a lot of these patients live anywhere from 30 to 40 years after their diagnosis. Two famous people with MS are Montel Williams and Jack Osborne. Montel is really rare because he's a black male with MS, which you see mostly is white females. With Parkinson's disease, Muhammad Ali and Michael J. Fox are probably the two faces that most people are familiar with now. Michael J. Fox developed it when he was in his 40s, which is very early onset Parkinson's. Muhammad Ali, we think, probably got it because of concussive injuries that he developed while he was boxing. But these are probably the most famous people with these diseases, and I know Michael J. Fox has his own foundation for Parkinson's disease and research, has testified before Congress, and has gotten a lot of light shed and put on research for these two disease processes.
Is that the one where he waited for the Congress to be like not take his medication?
He did not take his meds for a week prior to his testimony, so that they could see what his actual symptoms were before he testified. Because, you know, when you're taking your meds, it's not so bad. But whenever you don't take meds, you can tell that there's a significant difference in the way that he does that. But yeah, you watch his testimony, he's sort of like...
I knew someone did that, but I didn't know.
Yeah, it was Michael J. Fox. Now, we're going to talk about MS first. It's a chronic demyelinating neurologic disease of the CNS. Typically what you will see is it's of the brain, the optic nerves, and the spinal cord. Okay? So it's central nervous system. The onset for this is usually between age 20 to 50. All races are affected, however, Caucasians are affected much more commonly. There's been no definite genetic factor that's established. They think that it's an autoimmune response to environmental factors. And what those environmental factors are, we have no clue. Because one of the things that you will see it is that it's more of a disease the further away you get from the equator, the more likely that you are to have it. Like Northern Europe, the United States, those types of countries. But it's usually where you were born, not where you live. And we don't know what particular thing it is. What happens with MS is because it is an autoimmune disease, it activates the T cells. And what they do is they migrate in and out of the CNS, usually, but in MS, they remain in the CNS, and what they do is that they initiate an inflammatory process which destroys the myelin and the myelin-producing cells. What you're going to see with MS is it's going to vary with the area that's involved. There's no cure. Sometimes the prognosis will be different depending on the type. Like I said, the majority of these patients will live anywhere from 30 to 40 years after their diagnosis. But that's going to be, you know, if they were diagnosed at 20, they may die at age 50 to 60. basically what you're going to see is that the diagnosis for MS is sometimes very, very difficult, because what happens is that you will have an initial onset, and it may be followed by total remission, and then the next time you have a whole nother set of symptoms. Okay? So what you will see is that for 60% of clients with MS, they have what we call periods of exacerbation, which means they have symptoms. And they have periods of what we call remission, where they have no symptoms, or the symptoms are not as obvious. Typically, what you'll see is that you will have a progressive loss of function over the years. Now, pathophysiologically, like I said, what you often see is, remember that these are those lovely little nodes of Ranvier. So that what happens is that with a nerve cell, we have transmission of that impulse. It jumps from node to node, because this myelin will coat and protect that nerve cell. So you don't have to have that action potential along that entire nerve. But what happens with MS, you get scarred myelin, or the myelin is destroyed. So what you see, instead of jumping from node to node to node, it has to go along that entire nerve to get that information to either the muscle or back to the brain. So what you often see is delay in action or no action, because it takes so long for that nerve impulse to get there. With MS, sometimes they think it's due to viral infections, because we do tend to see more exacerbations in seasons that have more viral infections, like colds or flu. We see them more in the wintertime than we do at any other time. Typically, what you're going to see is that most people with MS will have exacerbations about twice a year throughout their lifetime. But some people will experience them much more often. Risk factors, like I said, peak age is about 30, primarily Northern European ancestry. As I said, Montel-Williams is unusual, because you see MS twice as more likely in females, but you see it predominantly in white Caucasians. The classifications, relapsing, remitting. This is the most common type, where you have periods of exacerbations or acute attacks, and then with either full recovery or partial recovery of their disability. In other words, what you often see is problems with double vision. And this may occur, and you will have a patient that has double vision for a month or so, and then it goes away. And then it may come back that they have problems with bladder control. So it sort of jumps around, because it's wherever the myelin is irritated and inflamed that causes those symptoms. Relapsing, remitting, exacerbation, period of remission where they get full or partial recovery of their functions. Primary progressive, you see steady worsening of the disease from the onset with occasional minor recovery. These people don't have that exacerbation recovery or remission cycle. They progressively get worse and worse and worse with very little recovery. Secondary progressive often begins as relapsing remitting, but the degree steadily becomes worse between exacerbations. And then lastly, progressive relapsing. It's rare, and it continues to progress from the onset, but also has exacerbation. Now, for my purposes and NCLEX purposes, probably what they will ask you is about this relapsing remitting. Okay? It's the most common type. It's the type that you will see most often, where you have periods of worse symptoms, and then you slowly get better. Maybe. It just, the symptoms vary from exacerbation to exacerbation because of the area that's involved. Okay? Now, diagnosis, as I said, is very challenging because it does not present uniformly. You don't have the same symptoms every time. But typically what you're going to see is to be diagnosed with MS. You have to have 2 or more exacerbations separated by 1 month or more, and they last more than 24 hours followed by recovery. In other words, you're probably never going to be see anyone diagnosed with MS the first time they come into the hospital for symptoms. And it may be the second time, or the third time. Or I've seen some people not be diagnosed for 2 or 3 years because of the periods in between their exacerbations, and they're not being seen by a doctor that thinks MS. Or what may happen is that they are referred to someone, they see their local MD, their family med doc, and then by the time that they get ready to see a specialist, their symptoms are gone. And then it happens again 6 months later. So you go through the process again. So sometimes it takes a while for this diagnosis to occur. But history of repeated exacerbations and remissions without complete recovery, followed by progressively severe manifestations lasting 6 months or more. This is one of those other types, okay? Or slowly increasing manifestations. This is that progressive MS. But typically, this is what you're going to see with that relapsing remitting. 2 or more exacerbations separated by 1 month or more and lasting more than 24 hours, followed by recovery. Diagnosis is very, very difficult sometimes. Now, what you often see, 50% of cases, visual deficits with visual blurring, fogginess, or haziness, impaired color perception, decreased central vision and acuity. Eye symptoms are going to be one of the first signs and symptoms that you'll see because of the optic nerves being affected. That double vision, that haziness, lack of color perception. Now, the other thing that I will tell you is these are also signs and symptoms of cataracts. So sometimes it's thought, well, maybe they got cataracts. But what happens is the difference between cataracts and this is this often gets better. Cataracts, the vision continues to worsen. If they have brainstem lesions, you may see nystagmus, dysarthria. What is dysarthria? Something that we had today.
Low feelings of pain.
Dysarthria is difficult speech. It's the muscles of their mouth. Sometimes their speech is garbled or they begin to mumble. Okay? Deafness, vertigo, vomiting, tinnitus, facial weakness, short-term memory loss, word finding and planning. one of the things that you will see is that not only does this attack the spinal nerves and the brain stem, it also affects the brain. So you may see those problems with concentration, short-term memory, word finding, and planning if they have frontal lobe lesions, temporal lobe lesions. Mood alterations. Depression is common, though a lot of times what you will see is emotionally labile individuals, laughing, crying in inappropriate times. Diagnostic tests that they tend to do, MRI pretty much is the diagnostic of choice, because what you will see are these spots, and these big spots are demyelinated white matter. CSF analysis, if they do see a lumbar puncture, will show increased T cells. CT scan or PET scan will measure brain activity. In what you will see with PET scan, these areas that are demyelinated will have low glucose uptake. So they have decreased activity. Evoked potentials, like that somatosensory evoked potentials, of visual, auditory, somatosensory impulses will show delayed conduction along those nerve roots. Huh? Yes. Sorry. All right. Clinical manifestations. Even though the rest of them are varied, these are what you typically see. Fatigue is going to be one of your primary symptoms. Stiffness. You may see flexor spasms. Intention tremor, dysmetria, visual findings, blurred vision, diplopia, or double vision. What is a scotoma? Floaters. Okay? If you've never had one, if you've never had one, you know what it is. It's that little black wiggly spot that goes in front of your eye, and you think, oh God, I'm seeing things out of the corner of my eye. But they're little, basically what they are is retinal hemorrhages, and it's the blood that's left in there.
Yeah, really? I get that a lot.
They're normal for most folks. It's when you have a bunch of them you worry about it. Nystagmus, and nystagmus, remember, is that jumpy eyeball. It can be lateral, it can be up and down, it can be sideways. Typically, we will do the range of motion for the eyes to elicit it. Visual findings and fatigue are the things that you need to be very, very important. Familiar with.
Visual findings.
All right, autoimmune, usually female. It can be familial, meaning that it tends to run in families, but it's not genetic. Okay? Nystagmus, diplopia, blurred vision, dysarthria, dysphagia, getting difficulty eating, urinary retention, okay, spastic bladder, constipation are common. And what you may see is that this weakness can progress to paralysis, muscle spasticity, ataxia, and vertigo. That vertigo is usually caused by damage to that brainstem, okay, where we have problems with balance, or the eighth cranial nerve, where you have the balance control center. Now, psychosocially, what you see with these folks later on, though you may see it in some people with lesions in that frontal lobe, is short-term memory loss, decreased concentration, inability to form calculation. Okay, no, we're not talking about giving them a math test. You may hear what we call serial 7s or serial 3. Take 100, minus 3 is, and then you see how far they can go. Okay? Now with 7s, most people couldn't get 1 or 2. A lot of times people with MS have problems getting them. Okay, because they're unable to concentrate. They may have impaired judgment. These are people that may be impulsive, again, because of damage to that frontal lobe. They may have weakness in their legs, but think they have to go to the bathroom, so they get up and fall. Okay? They don't recognize the need for help. Apathy, emotional liability, and depression are common, especially during exacerbations. Medications are not a cure. Nothing will cure MS. But what we are trying to do with these meds is to decrease the number of attacks that these people have. Because if you decrease the number of attacks, then what you're going to see is less of the consequences long term. Okay? With relapsing remitting, typically the course is exacerbation, full recovery. The longer that this person has MS, the less likely they are to develop full recovery. And so what you often see is 40 years into this disease process, they may be wheelchair bound because they're unable to walk and hold themselves upright on their own leg. So what we're trying to do is decrease the number of attacks so that we will try to keep them as functional as long as possible. We're trying to give them meds to reduce inflammations during exacerbations, because when they're having those exacerbations, that's whenever inflammation is causing destruction of that myelin. So we want to decrease the inflammation. We also want to inhibit some of the other manifestations and to induce remission. Now, some of the other meds that we give them not only are for the MS, but you might see skeletal muscle relaxants. We might see bladder relaxants. Okay? We may see other types of meds being used in addition to what we give for the MS. Now, it's a good thing that Ms. Beaver talked to you about some of your immunomodulators, which she talked about cancer, because we use some of the same types of meds for MS. Interferon beta 1A or Avonex, interferon beta 1B or beta seron, or glatiramer acetate or Copaxone are given for relapsing remitting to prolong the time of onset to the time of disability. In other words, what these meds do, the immunomodulators, is decrease the number of exacerbations that these people have over the lifetime, and therefore prolong the time of onset of the disease to the time of disability. These may be your people that do last the 40 years without being wheelchair bound, okay? Versus the people that may not take these medications and only have a lifespan of 10 years without being wheelchair bound. The quicker that we can get people on these medications, the more likely they are to have a normal lifespan with as little disability as possible. Now, what these do is they decrease the lesions in some patients. Now, our side effects are not without cause. They will decrease the ANC, absolute neutrophil count. They will increase liver enzymes, your ALT and your AST. They can cause confusion, depression, suicidal tendencies. And depression and suicidal tendencies are not a good combination. The other thing that I will tell you about these meds is they have to be given sub-Q on a daily basis. They need to rotate their injection sites because a lot of times they will cause irritation of the skin. So they want to avoid hardened, reddened areas where they've given previous injections. They need to avoid prolonged exposure to sunlight because these drugs will make them photosensitive. One of the things that I will tell you about these medications, though, guys, is that a large majority of patients take their own self off of them within 6 months after starting them because you feel like you've got the flu all the time. You have that muscle ache, you have the headache, you have the myalgias, you just ache all over. And that's an expected side effect of these medications. Pregnant women should not take them. Other immunomodulators, now any of the MABs, okay, this one is an IV infusion. So they have to go to a clinic to have this one infused. They can have allergic or anaphylactic reactions from this medication. It does damage liver cells. So monitoring AST, ALT is very, very important. The other thing that you need to remember about these is that it can cause progressive multifocal leukoencephalopathy. What in the heavens is that? Well, what it is that you have leuko means what?
White.
White. Encephal means brain. Pathy means disease. So what happens is that you will have an increase of white cells in your brain. And it's like a cancer. And it can cause a severe dementia. Fingolimod is the first oral med that's been approved for the management of MS. All of the others have been sub-Q or IV. This is the first oral. Okay? One of the things that you need to remember is that it can be taken with or without food, but these patients need to be taught about checking their own pulse, because it can cause a bradycardia that can become severe. Now, immunosuppressant meds that we may also give, azanthopryne or cyclophosphamide, Imuran or Cytoxan. I know Ms. Beaver talked about some of those. They suppress the autoimmune component of the disease, but they can cause bone marrow suppression, okay, because they're immunosuppressants. We will have people with low white cells, low neutrophils, and even sometimes with low red cell counts as well. And they increase the risk of cancer. Imuran can cause hepatitis. So if you didn't feel bad enough taking your immunomodulator, now you have hepatitis and then you really feel sick. And then you're vomiting all over the place. CBC platelet counts, urinalysis, LFTs, those are your liver functions and your hepatitis profiles. With these meds, you need to assess for anemia, lethargy, fatigue, pallor, and bleeding. Now, what about this med right here? What is one of the things that I need to be very careful about with giving that to a patient? Hydration, because it can cause what? Hemorrhagic cystitis in the bladder. Okay? Increased fluids on those patients. And I'm going to tell you, on most of your patients with MS, you're going to get pushback. Because that means I have to get up and go to the bathroom more often. Well, would you rather get up and go to the bathroom more often than bleed in your urine? I think so. Okay? So immunosuppressants. Because one of the things that we're working on is the immunomodulators to decrease the myelin breakdown. These immunosuppressants to decrease some of that inflammation. Okay? Now let's talk about adrenocorticosteroids. These are used during those exacerbation periods. Typically what you will see is that patients will come into the hospital and they will be put on prednisone or methylprednisolone as medication, IV medication. What we're trying to do is to decrease that acute inflammation and to put that person into remission. They suppress that inflammatory response. They suppress that immune response. However, high-dose steroids, because these are, mine does that too. What they will do is they result in bone demilitarization. Remember, we saw that with osteoporosis with high-dose steroids. Okay, we also will see an elevation of blood sugars. The other thing that I will tell you that you have to watch your patients for with high-dose steroids is steroid-induced psychosis. Okay? They get wacky as all get out with these meds sometimes. Because remember, you've already got a person that has MS that's emotionally labile. You put them on this high-dose steroid, they will have trouble controlling their emotions. They will have trouble controlling their thought processes. And often confusion is a problem that you will see. Hallucinations are not uncommon with a lot of these patients. High-dose steroids also will not allow them to sleep very much. They get the jitters and insomnia. Usually these are given IV on running doses Q6 hours. What are some of the other things you really have to worry about with steroids? Blood sugars, okay? If you have a patient that's diabetic, you probably are going to have to cover them with a sliding scale because they will not be able to control their blood sugar with just diet anymore. Okay? You have to be careful with these patients that I've never taken insulin before. I don't need it at home. Well, you don't take 10 milligrams of prednisolone or 60 milligrams of salmeterol. Okay? on a regular basis at home. So you're going to see some altered blood sugars, and you may see 300 or 400. So you've got to be very careful with their blood sugar. Even though they're not diabetic, these patients that are on these steroids need to be on AC&HS or Q6-hour blood sugar checks. Because even if they're not diabetic, it will cause an elevation in their blood sugar. Okay? All right. We're going to call it a day here, and we will go to muscle relaxants
Monday.
next week, next Monday.
Tuesday.
Tuesday. No, the test is Tuesday.
Yeah, that's what she was asking.
Yeah, the test is Tuesday, but the class is Monday.
Precisely.
All right. Like I said, I'll try to get rid of this.
Nobody talk to her so she can exit the room. So nobody talk to her so she can exit the room.
Louie's already got
No, she doesn't last. She said she
Because I know that,
For those of you that are on Thursday, Friday clinical, don't forget tomorrow is Thursday.